Now we're going to see hemochromatosis. Let's remind the metabolism of iron. We have the intestine, liver, and most tissues. Here we just care about the intestine and the liver. The absorption is mainly in the F2 plus iron, that is the ferrous state. This will be absorbed by this divalent metal transport. Then would be passed here into the bloodstream through the ferroportin, this is ferroportin, and would be transported into the liver, to all the organs by the transferrin. Now transferrin binds more to the iron on the 3 plus state, so in the ferric state more than on the ferrous state as opposed as here in the absorption. Now the way by which the iron passes from iron plus 2 to iron plus 3 is the ceruloplasmin. Ceruloplasmin, we will see it on copper metabolism, but is this enzyme that is ferrooxidase. Ceruloplasmin is the same as ferrooxidase. So in Wilson disease, in which the ceruloplasmin is low, that is not the primary cause. The primary cause in Wilson disease is that this copper could not be put on the ceruloplasmin, but the ceruloplasmin would be low, and so there are also iron problems on Wilson disease. Alright, now, so the transferrin transports the iron and the transferrin, this complex, will bind to this receptor, they will be internalized, and the iron would be storage here as ferritin, and also could be used by or to make part of other enzymes like cytochromes, etc. The liver has some enzymes here like the HFE or beta-2 microglobulins. These are enzymes that sense the levels of iron. So if the iron levels are low, then this liver will do that the ferroportin expression will be high, as well as that of the divalent metal transport. The way by which this ferroportin is regulated is the liver can release epsilin. Epsilin will decrease the expression of ferroportin. When the liver sends a low state iron, there will be less release of epsilin, and so a high expression of ferroportin. Now, in hemochromatosis, the problem is a mutation on this gene, HFE. So the patient falsely sends a low state iron, and so there will be increase on the ferroportin and the valent metal transport. So there will be massive absorption of iron, even though the patient is full of iron, because the liver is sensing falsely low levels of iron, but actually the patient is getting overloaded of iron. So this is the pathophysiology. Now, how will we find on the labs? There will be massive absorption of iron. There would be an increase in the saturation, in the percentage saturation of the transferrin. As you will see, all the transferrin will be saturated with iron. The ferritin would be high because there is a lot of iron, so there would be a lot of iron that would be stored, not here, not on the liver, but in all the other tissues. So the ferritin would be high. The total iron binding capacity. Remember, total iron binding capacity is exactly goes the other way around as the ferritin. So if this is high, this is low. But to do it intuitively, it is the total iron binding capacity is not how many transferrins there are. It is not just the number of transferrins. It's how many available transferrins are. So how many transferrins that are not bound with iron. Here, the percentage of saturation of the transferrin is very high. So almost all the transferrin is full with iron. So the total iron binding capacity would be low. And each time, in every iron study, the ferritin goes the opposite way. That is, if the ferritin is increasing or decreasing, high or low in comparison to the normal, the total iron binding capacity will go to the other side, and vice versa. So each time you need to check that if one is up, the other will be low. every time check that. It doesn't matter if you want to begin to see this and then you know that the other needs to be the other way around, or you begin with this. I think that most of the students do it first with this. I think that because at the end they don't realize that this is intuitively, but now that you know how to do it, you can do it intuitively. You don't need to see this and then think how it's going to be the other. But just for confirmation, you can do that. So you know how it's going to be, and on the report you check it. Alright. Now the patient would have a mutation on the 282 amino acid. This is a mutation that replaces the cysteine with other amino acid. And the problem would be this low sensation of the iron. The patient would present with iron overload, so the damage will be primary on the liver because the iron is being deposited in other tissues, because the iron can enter by this transferrin complex receptor. So the iron can enter to the liver. Actually the ferritin is very high. The iron can enter to the liver, but the liver sends fastly levels of iron, even though the liver is full of iron, because the problem is here, not here. So the liver is absorbing a lot of iron, so the main problem would be in the liver. The most common cause of death is due to cirrhosis. The patient would have liver failure, cirrhosis, etc. There are other organs that are affected by the iron deposit, like the pituitary gland. This could lead to atrophy of the testicles, so hypogonadism. There is also iron deposition on the sometimes on the skin. This would be called, remember, a skin deposition, for example, of iron is in a secondary cause, that is in a acquired cause. For example, a lot of transfusion, like in beta thalassemia, it is called hemosiderinosis or something like that. Hemosideronemia if it is in the blood. But if it is a congenital, like this is not present at the time of birth, but the mutation is, the patient born with that mutation, so you can think it as a congenital in that sense, and you know that is hemochromatosis. The patient would present mostly like at 40 years of age, but in women would be presented at a later age because they have menstruation and so they can get rid of iron. Now, the only organs that are not affected would be the kidney as opposed to Wilson disease. The eyes are not affected as opposed to Wilson disease. And one very important, the joints are affected. This would present with involvement of the metacarpopharyngeal joints, mostly the second and third ones. And there will also be some calcium deposits, higher phosphate calcium deposits, so the patient would present with chondrocalcinosis, also called pseudogota. Alright, now the diagnosis would be the best initial test. So whenever we suspect this, we need to first look for the iron studies. These iron saturation, transferrin percentage, the ferritin, the total iron binding capacity. The percentage of saturation is calculated as the iron divided by the total iron binding capacity. And if this is greater than 45%, it is very, very, very suggestive of hemochromatosis. So this will be the best initial test. The way by which we are going to ask this or suspect this is the patient has liver failure. It could be cirrhosis, just in the hepatic enzymes are elevated, and the patient have a bronze appearance of the skin. This is due to iron deposition as well as increased melatonin secretion. And these patients also can develop diabetes mellitus type 1 because the pancreas would be affected and it's completely knocked out the pancreas, so it is type 1 diabetes mellitus in which there is no insulin. So this is why we are going to suspect that the patient has this hemochromatosis and not just a liver damage by hepatitis or something like that. No, we are suspecting hemochromatosis very much because of also the presentation on the skin. So we will ask for the iron studies. Next, we will ask for the genetics. That is, we will have various studies. In genetics, we can have mutation on this on the gene S200 C282Y, that is this protein that is encoded, or a mutation on the CDH63. We can have a patient that is heterozygous, so one mutation here and one mutation here, or a patient that is homozygous with two mutations here. The most accurate test is to do a liver biopsy and then staining it with blue stain, Prussian blue stain, and in which the iron looks blue. Sometimes we can skip the biopsy if we find that the patient is homogeneous to this mutation, the C282Y, and in a MRI we see the iron deposition on the liver. If this is the case, then we can avoid the biopsy for those patients. So, if a patient is homozygous to C282Y, the next step is to do the MRI because we want to avoid the biopsy. The treatment is weekly phlebotomy to keep the iron levels to normal, and then when they are normalized every 2 to 4 months, we will do the phlebotomy. If the patient cannot tolerate phlebotomy, sometimes we can give iron chelators. This includes deferoxamine, deferipron, and deferasirox. The deferasirox and deferipron are the ones that are oral. Patients with hemochromatosis can present with diabetes mellitus, with problems in the pituitary gland, and all sorts of things. But the main presentation would be liver failure and some abnormality on the skin most of the time, and that is why we think that the patient can have hemochromatosis. We begin with this best initial test, the iron studies, then the genetics, and then we see if we need to do the biopsy or we can avoid it doing a MRI if the patient is homozygous for this mutation. And the screening for the hemochromatosis is when we find a transferrin level greater than 55%.